What is the myocardial infarction? It's a heart attack. This is death of heart muscle tissue due to a prolongation or prolonged severe ischemia, loss of blood and oxygen. Lots of different risk factors. One of them being postmenopausal women due to drop or AFAB individuals due to drop in estrogen. And atherosclerosis, of course, big risk, primary underlying cause. If caught late, necrosis or actual full death of cardiac myocytes, cardiac muscle cells can occur. And of course, over time, chronic coronary artery disease, heart failure, and death can happen. The ischemic injury can sometimes be reversible if it's caught early enough. And this is kind of showing what happens from a pathophysiology perspective. We can see sometimes these different kind of potential complications that can occur. So in myocardial infarction, the complications by time frame, I think this is a lot easier to look at. And we even have a mnemonic here for DART Vader. But within 0 to 24 hours, you're seeing things like ventricular arrhythmias, VTAC, VFib, etc., or even SVT, heart failure, and shock, cardiogenic-based shock. Now, if the patient survives this, then you're looking at in 1 to 3 days, you can see some fibrosis, so post-infarction, fibrinous, pericarditis, inflammation due to uh, stiff heart, swelling in the heart, essentially leading to lack of movement because it's stiff because there's only so much space that the heart can swell. 3 to 14 days, you can see cardiac tamponade. That's when fluid fills up that pericardial space and reduces, again, movement of the heart wall. You could see mitral regurgitation or a left ventricular pseudoaneurysm, things that you're seeing on this page. And then over the course of 2 weeks, you can see Dressler syndrome. That is a pericarditis, heart failure, arrhythmias, or even a ventricular aneurysm. So DART, Vader, death, arrhythmia, rupture, tamponade, Vader, or tamponade heart failure, Darth. You can have the H, Darth Vader. And then Vader, valve disease, aneurysm, Dressler syndrome, embolism, and recurrence or regurgitation. How does it happen? Well, the initial event is a sudden change in a plaque. This could be a hemorrhage of a plaque, an erosion, an ulceration, or rupture or fissuring. Then, when that happens, the body's going to signal its clotting cascade. So, platelets will adhere to the subendothelial collagen. They will then activate the platelet plug in the clotting cascade. They will aggregate, and then there can be microthrombi that occur. That oftentimes also can trigger around the same time of vasospasm because there's platelet mediators that are essentially being activated. So we know when we have injury to a vessel, we vasospasm, we vasoconstrict initially, we create a platelet plug, and then we coagulate, right, with our clot. So this is all like normal response to damage or injury. The problem is it was due to a plaque, right? It wasn't actually the vessel that got damaged. Then tissue factor will activate the coagulation cascade and a thrombus bulk will increase. The thrombus gets larger in size. The thrombus gets large enough to completely occlude the lumen of the coronary artery within minutes of this process happening, which leads to ischemia, lack of oxygenation and blood supply to the area, and then muscle cell death at whatever region was supplied by the affected artery. Biochemically, you'll see cessation of the aerobic metabolism process within seconds. So aerobic respiration stops within seconds because we lose oxygen. Therefore, there's not enough ATP, and there's an accumulation of lactic acid in the heart, which the heart does not operate well without oxygen. It is a high volume, high energy tissue. Microscopy wise, in 0 to 24 hours, you'll see kind of wavy fibers. Coagulative necrosis is the type of necrosis, and darker eosinophilic pink staining stripes. In the 1 to 3 days, you'll still see coagulative necrosis now with neutrophils that have infiltrated, signaling acute inflammation. In 3 to 14 days, you see macrophages coming in to try to heal the tissue, and they're laying down granulation tissue to try to heal up, essentially like a partial scar, a temporary scar. And then around 14 days or more, the scar formation is complete. But that tissue, if it fully died, those cells, is no longer functional. Now, there are two kind of major categories of myocardial infarctions, NSTEMI versus STEMI. Either can occur, have pain with rest. Both will have elevated troponins. The infarction is typically subendocardial for an NSTEMI versus transmural, full thickness for a STEMI. EKG, oftentimes with an NSTEMI, you see ST depression versus you'll see ST elevation with a Q wave for a STEMI. And again, the NSTEMI is oftentimes in the inner portion, the subendocardium versus the STEMI is a full thickness of the myocardial wall. Clinically, oftentimes the most common occluded arteries from most common to least would be left anterior descending, right coronary, and then circumflex. So that's high yield. I'd remember that. Clinically, it's kind of the classic symptoms you'd expect to see with a myocardial infarction. There's no really exciting or new ones here. It is important to know that AFib individuals and patients with diabetes could present very atypically with just nausea and vomiting, jaw pain, or even just fatigue with no chest pain at all. Here is your Darth Vader acronym or mnemonic that shows the complications, if that helps remember. All right, so we're going to pause and then we'll come back and practice.